Good morning, chairpersons, dear colleagues. I'll be talking about the role of routine thrombectomy in primary PCI. So why thrombus aspiration at all? Does it make sense to aspirate thrombus? As we all know, acute myocardial infarction is secondary to plaque rupture and thrombotic occlusion of the coronary artery. So just balloon dilating and stenting these patients will invariably result in some degree of distal embolization and often slow flow or no reflow. Thrombus aspiration converts TIMI 0 or 1 flow to TIMI 2 or 3 flow in majority of the patients. And it helps in delivering the antithrombotic and antiplatelet drugs to the desired site, that is distal to the thrombotic occlusion. So pre-dilatation can often be avoided, and lesion's length is often better defined after thrombus aspiration. What are the concerns? Concerns is that there may be a risk of distal embolization by the device itself. It may be real, but it is very small. And the risk of dissection is actually non-existent pretty much. Additional time and equipment, again, it is negligible. So need for pacing, it's only with the angiojet and not with the manual thrombectomy. Here is a patient who presented with the anterior wall ST segment elevation myocardial infarction. See the LAD is occluded distal to the diagonal. So don't see it, you don't even see the stump. So we were able to pass the wire and did a thrombus aspiration. And you see that the vessel is completely recanalized and there is no significant residual lesion. So no balloon, no stent. And this patient is doing well almost 2 years now, has not had any recurrent events. This is another patient with young patient, 22-year-old, came with ST elevation anterior wall myocardial infarction, and this is a large left antidescending artery totally occluded with thrombus. All that we did was just thrombus aspiration. And there's still some residual thrombus. We gave him intercoronary urokinase and also intercoronary efiximab and left him alone. And we rechecked a few days later, it's completely recanalized. So this patient also is doing well about 6 months into the procedure. And his parents especially requested that no stent should be done. He's 22 and he has to get married. So they didn't want to have that stigma of having an angioplasty at a very young age. So this is another 45-year-old gentleman presented with anterior wall ST elevation MI. LAD is totally occluded, distal, mid. So again, just thrombus aspiration. It's not playing. Yeah, sorry. So complete recanalization, no balloon or no stent. So in other words, these are some extreme cases where we are able to get excellent flow, and the angioplasty procedure itself is made very simple. In other patients, you are able to aspirate and show the lesion length and then go ahead with the intervention. Now, there are two types of thrombectomy procedures, manual and mechanical. The exciser and the angiojet and the TrombCat, these are not very routinely used. The angiojet trials have been mixed. The last trial, the jet stent trial, was slightly positive. This showed significant ST segment resolution with the angiojet compared to the routine conventional angioplasty. However, there was no difference between the surrogate endpoints. At 6 months, thrombectomy arm had a lesser MACE rate, and also at 1 year, there was statistically significant difference in the MACE rate. So although initial angiojet trials were negative, the last one was positive. Still, it is cumbersome, expensive, so not very popular. On the other hand, manual aspiration trials have shown better results, and it is simple to perform. The initial randomized trials have shown improved myocardial blush grade compared to routine angioplasty without thrombus aspiration. And then came the large randomized trial. 1,071 patients underwent randomization, and this again showed significantly better myocardial blush grade with thrombus aspiration compared to with conventional PCI. And also ST segment resolution was better in the thrombus aspiration group compared to the conventional PCI. And this translated into death, reinfarction at 30 days. Again, myocardial blush grade 3 had very low mortality and the events. And although the difference was not statistically significant at 30 days, at 1 year it became significant. There was significant reduction in mortality. So this trial, all the subgroup analysis also indicated that most subgroups, the thrombectomy group did better. Even in patients who had large amount of thrombus, there was a trend towards better outcome. In patients who did not have large amount of thrombus, there was a trend towards better outcome with the thrombectomy. So next came the TASTE trial, and this is the trial for the reason why which we are discussing this procedure here at all. And this is a registry-based randomized trial, a new concept. And the data was obtained from the online health quality registries, SCAR and Sweetheart. About 11,000 patients. Out of that, 7,259 patients were enrolled in randomized trial. Please note that around 4,697 patients were not enrolled in the trial. And this is a significant point. And no patients were lost to follow-up. There was no significant difference in the baseline characteristics. Please note that the time to PCI after the onset of symptoms was about 3 hours, which is not the case in our country. There was a slightly higher incidence of use of 2B3 inhibitors in the PCI arm. And direct stenting was more often performed in the thrombus aspiration group compared to the PCI only group. Note that the number of stents used was statistically lower in the thrombectomy group, and also the length of stent length was statistically lower in the thrombectomy group. The X-ray time was slightly higher. And all-cause mortality at 30 days was not statistically significant. Please note that the mortality was 3% in the PCI group and 2.8% in the thrombectomy group. Reinfarction, again, not statistically significant, but shows a trend favoring thrombectomy. Stent thrombosis was, again, less with the thrombectomy group, but not statistically significant. At 1 year, they did not find any further improvement in the results. In fact, stent thrombosis was less significant at 1 year than at 30 days for strange reasons. So what are the limitations of TASTE trial? First of all, it's a registry-based trial, and out of 12,000 patients, only 7,250 patients were randomized. That means around 5,000 patients were not randomized. And the mortality in the randomized arm versus the non-randomized arm is significantly different. That means this is a patient, they have selected only low-risk patients, so not included all patients. There is a inherent ascertainment bias, and there is underrepresentation of high-risk patients. And there's no independent data monitoring or central adjudication. And they use 6 French aspiration catheters. And there are studies which have shown that 7 French catheters are better than 6 French for getting better results. So, in fact, in my opinion, TASTE trial supports thrombus aspiration because all the endpoints, there's a favorable trend with the thrombus aspiration compared to the conventional PCI. There is, in fact, 60% relative risk reduction in the incidence of stent thrombosis at 30 days, 40% relative risk reduction in the incidence of recurrent MI and rehospitalization at 30 days. And it reduces the number of stents and also the length of the stents. And it's difficult to show mortality at low-risk AMI subset. I think that is one of the key points because you've included patients with very low-risk group. So it is difficult to show mortality benefit. And there was no increase in stroke risk. So there's no real adverse effects with stent thrombosis. The final word on thrombectomy is not out yet, and there is a large randomized trial is going on, US-based, and the results are yet to be published. So in my opinion, routine aspiration is a no-brainer. It prevents distal embolization, lowers the incidence of no reflow, and helps visualization of the coronary anatomy better. It facilitates direct stent deployment, and it's relatively cheap. And no study has shown any adverse effect with the thrombus aspiration. Surrogate endpoints such as ST resolution and myocardial blush grade show consistent improvement in all trials. And there is mortality benefit at 1 year in one major randomized control trial. And of course, the stent size, the length and the numbers are reduced by thrombectomy. And there is a strong trend towards lower incidence of stent thrombosis and recurrent myocardial infarction. So guidelines so far still have kept in the class 2A. So in other words, routine aspiration thrombectomy should be used in most patients undergoing primary angioplasty, especially those with baseline TIMI 0 or 1 flow. It may be avoided in patients with discrete lesions with baseline TIMI 3 flow. Thank you very much for your kind attention.